So my talk today will be about rapidly progressive dementias. And although I'm not necessarily a dementia expert, I have to think about rapidly progressive dementia a lot as a neurohospitalist. So my talk is kind of based on my experience as a neurohospitalist dealing with this type of consult and these types of patients. No disclosures. The outline, I think it's kind of good just to differentiate between what dementia is and what a rapidly progressive dementia is. Talk a little bit about the history, workup, and treatment, and then give a little bit about the differential for rapidly progressive dementia, also known as RPD, and then talk about some cases. Okay, so dementia, I think that's kind of where we should start off with. Dementia essentially is cognitive and behavioral changes that significantly affects one activities of daily living. And so when you think of rapidly progressive dementia, really the only difference is it's the same thing of cognitive and behavioral changes, but the added part of rapidly progressive refers to these changes occurring over weeks to months. So quicker than you would anticipate a typical dementia. And just to kind of clarify what we talk about of activities of daily living, these are just basic things: feeding, urination, bathing, dressing yourself, using a telephone, preparing food. These are very simple things that when you hear someone that can't do it and they were able to do it, it should be concerning for at least a dementia. So I like to always kind of start from the beginning, and this beginning will hopefully just be like a reiteration for most of you guys, but I really think that it's important just to kind of go over the basics. So with a dementia history, I think that whenever you try to get this type of history, the collateral is always important, as the patient is usually impaired and will give you a very limited or skewed view of why they're there. Establish their baseline. It's really important to know, well, prior to all this, what were they doing? What were they at their best, thinking wise, motor wise? And you can even use the level of education as like a marker of, well, this is kind of how high they achieved. This is what they were able to do. And so this is what I would expect for them to look like, at their best. Describe what the patient is not able to do at home and work and use specific examples. And same thing, describe what the patient is able to do at home and work with specific examples. So remember, we talked about cognitive and behavioral changes as like kind of the two things that patients with dementia should exhibit. So here I kind of broke down kind of what cognitive changes mean, because patients will say one thing, and I think as a neurologist, you should be thinking about, these in a different way. So for example, patients will say, my mom has poor memory, and you need to kind of elaborate on that. Is it short-term memory? Is it long-term memory? It can't just be poor memory. When they say, I have word finding difficulties, you as a provider should be thinking, is this a language issue? Are they having trouble understanding? Is it getting out the words? Are they having trouble spelling, reading, writing? Like, how much of it is words finding difficulties? Or they don't recognize names and faces anymore. They're just very, very forgetful. Is it an eye issue? Like, can you not physically see anybody? Is it a visual processing where they can't interpret what they're seeing? Is it just their memory? They really just cannot remember these names and faces. And so with behavior changes, patients and family will say they're not acting like himself or herself. And you, as the neurologist, or they may say no interest in X, like in watching TV, and whatever hobbies they used to, or they're more anxious or irritable. These are kind of behavioral changes, right? Or they're hallucinating, they're talking to himself, or they see blank when it's not there. And so you, as a neurologist, When you think about these behavior changes, you kind of have to kind of acknowledge that, hey, this is not what their baseline is. And as a little side note, with hallucinations, if they really have a predominant auditory hallucination where they're like somebody's talking to them, usually it's very rarely a non-psychiatric problem, meaning like it's just primarily just neurologic, like encephalitis or a dementia. You know, visual hallucinations are another thing, but auditory is usually primary psychiatric. So some pitfalls of taking the dementia history. You know, patients will say these things, or family will say these things, and you should kind of, you know, really, you know, take things with a grain of salt. Like it all started after this accident or this operation, because people, like by nature, people will like to fixate on like specific life events and like put things around that one life event. Like it all started with COVID. It's a big one recently. You know, everybody thinks that their symptoms started after COVID, and so you have to kind of just kind of take it with a grain of salt. Or they're going deaf or not listening. You know, like they're being inattentive. Are they really inattentive, or can they just not actually process what you're saying, or they cannot see? You know, so it's just sometimes these types of phrases don't mean enough on their own. They've always been spiritual. You know, they've always thought this way. This is something that's very common for them to believe in these like odd things. So once again, just take these with a grain of salt. Probe the history before the event. So, you know, they talk about this happening after this event. You should, you know, always go, well, let's talk about before this. Well, what was happening before this, et cetera, because you sometimes need to make your own timeline. That sometimes people aren't necessarily aware of. So additional dementia history, things that you don't always think about asking, but we should, because they would really help support a story for dementia, such as what their wake and sleep patterns are. Dementia patients usually have very poor wake sleep patterns. Medication changes, those are really important, especially as you get older. Your body's very easily susceptible to minor changes, increasing, decreasing, missed doses, et cetera. Active and inactive medical problems, of course. Level of education, prior occupations can be very helpful, what trades they were in. And then it's just more neurologic history, like the typical neurologic history that you would take. Are they having dementia symptoms, but also they have headaches or also dizziness? Oh, they're actually choking on foods, moving slower, falling over, more clumsy. These additional neurologic symptoms can kind of, once again, narrow down what's going on. So about the physical exam. So obviously the mental status is, we'll say, the most important thing. And just, you know, the easiest thing to do is you observe the patient when they are not being watched. So usually there's a family member in the room, and sometimes you have to talk to the family member. But while you're talking to the family member, I mean, usually like I like zone out sometimes because they like talk on and on. So sometimes I just focus on the patient to see what he or she's doing. Are they like listening? Are they just like, you know, zoning out? Are they asking their own questions? Like, what are they doing? Because that can be very helpful. Did the patient answer their own questions? Are they deferring to the collateral person? Do they have even any insight into their medical problems? Do they even know why they're here? Do they shrug off incorrect answers? This is a pretty big one where they're just like, oh, you know, I knew that, or oh, that doesn't matter. You know, that's not really a sign that they actually did know what's going on. Do they even acknowledge the right answer after correcting them? Are they just kind of just, once again, ignoring what you're saying? Are they frustrated with your questions? You know, sometimes you think that people are frustrated because, oh, these are silly questions, but it's their defense mechanism that they truly are demented and they just don't know the answer, but they are unfortunately have no insight that they don't know it. And so they just show frustration. And you as the examiner, you want to kind of back away because you're like, oh, they're frustrated. I want to like, not provoke them. But it really helps to know, if they're frustrated, that, hey, they probably don't really know what's going on. And then their attention. Did you have to repeat yourself multiple times just to ask one simple question or to do one simple thing on the exam? So beyond just, alert oriented ×3, naming, comprehension, repetition, there are more specific things that you can do in just the mental static examination. Like just within the language category, you can just look at their speed of their words that they say. Are they saying things in a normal cadence? Are they just very slow to respond? Are these short phrases that they're saying, answering with, or complete sentences? You can even try to do more things like spelling, writing, and reading. With their memory, short-term recall, we tend to do very often. And then this I obviously don't do very often because it's pretty intense, but you can just do a lot more higher order things like calculations, abstract thinking, what's similar between an orange and an apple, complex tasks, and then something called an agnosia. So basically an awareness of like their body and kind of spatial awareness. Like, are they ignoring the right side of their body? Or when they're looking at a picture, they're only describing one part of a picture. And then the rest of the physical exam, very important, but I'm not going to like harbor on the whole physical exam. I don't think that that's kind of the purpose of this talk. But Parkinsonism is very important, and you can see that with the motor examination. Dyskinesia is abnormal movement. The coordination, looking at ataxia, that can be very helpful for a patient with ataxia plus some dementia symptoms. Gait disorders, if they're demented and they're having gait disorders, that's not really common in Alzheimer's. Patients with Alzheimer's usually are able to walk pretty well. So if they're having walking issues and you can't explain it other way, something else is going on causing their walking issues and dementia. And then frontal release signs, things that I think that maybe you've probably heard once upon a time, maybe learned in pediatrics, but don't test it enough to kind of know what it is. But basically, they're like kind of like primitive signs that if you have some like large brain dysfunction, especially patients with dementia, you have evidence of these signs that can kind of be brought out whenever you have dementia. So like glabella is one that I commonly do.
Reflex that can be elicited by repeated tapping on the patient's forehead. You should instruct the patient to keep their eyes open whilst you tap on their forehead. If the patient continues to blink, this is a positive glabellar reflex and might indicate potential Parkinson's disease. It's known as Meyerson sign. So now I'm going to tap against your forehead here, and I'd like you to try not to blink and keep your eyes wide open for me. Is that okay?
Yes.
That's normal. You and I should hopefully do that. Abnormal. Seeing patients with dementias, or just in general, just patients with like brain injuries, we'll say. So let's go to causes. So like now we're focusing more on just like rapidly progressive dementia. So that was basically about the dementia history. You got the history, you did the exam. You've basically solidified, hey, this has been going on for weeks to months. Okay, so what can cause this dementia that has been only going on for weeks to months in this patient? And so vitamins P is like a mnemonic that is kind of like variation on vitamins that people tend to use as a mnemonic for most etiologies, but it's really broad for RPD. It's vascular, infectious, inflammatory, toxic metabolic trauma, autoimmune, metastasis, medications, mitochondrial, iatrogenic, neurodegenerative, the big one, systemic things, seizures, sleep disorders, and then psychiatric. I'm not going to go through all of this, but they're there to review. Like within each category, there's some more common ones that I think that we'll see more often, especially in the inpatient, highlighted in orange. And then within these other categories, here are some other ones that are commonly common. I'm not going to necessarily go into details about these because not really the scope of this lecture. Okay, dementia workup. Not going to go over it either. This is not necessary, but just wanted to kind of show you in a broad sense. This can be a very extensive workup if the clinical picture is very confusing, or if there are just like no clues on your exam and history, which is very rare. You can really do a really broad workup in the blood for autoimmune, infectious, metabolic things. And similarly, in the spinal fluid, you can do quite a bit as well. Obviously, less than the serum, but you can do a lot of things looking for autoimmune, infectious, neoplastic, neurodegenerative things in the spinal fluid. So that kind of reiterates that you need serum and most of the time spinal fluid for these diagnoses. Other things that can be helpful: imaging. We love to look for structural problems in the brain, especially. And besides just the brain MRI, there are other dedicated tests looking for more specific things in the brain, like metabolism with a PET, dopamine with a DAT scan, and things like amyloid and tau, which, for the sake of this talk, really can't be done in the inpatient. EEG is helpful as well, skin, meningeo, and brain biopsy as well, because tissue usually is always gold standard, but it's not very commonly done that we get brain biopsies. So yeah, these three things like DAT scans, amyloid, tau, not very commonly done in the inpatient. It's really a research basis. It's not commonly accepted as a tool to use because it's so unique and is not like proven to really help clinical outcomes at this time. I'll go over some head imaging, just more so just to show really the point of these imaging is just to kind of show we'll say patterns of atrophy that can be seen with different types of dementia, so just dementias in general. I'm not going to go into really more details than that, but like Alzheimer's, you see a lot of temporal more than parietal atrophy, versus dementia with Lewy body, you can see a normal brain and very little atrophy. That's kind of interesting, because dementia with Lewy body is actually the second most common dementia, and you can almost have a normal brain, which kind of once again reinforces how important your history and physical exam is. Frontal temporal dementia, like the name says, frontal and temporal atrophy. Cortical basal degeneration, so it's asymmetric. One side usually has more atrophy than the other. It kind of goes with the presentation. Usually it's an asymmetric presentation. Progressive supranuclear palsy, so the atrophy is usually more in the posterior fossa, the midbrain, pons, cerebellum area. And Huntington's disease, caudate atrophy, so only very unique structures in the brain, and it's usually with that caudate atrophy, there's enlargement of the frontal horns. Okay, dementia management, just broadly speaking, somebody's demented, they're like, I want something to help. Dementia meds are like the easy answer, like donepezil, memantine. These, how I try to talk to patients about them is, they're not going to prevent the dementia from happening or from occurring. They're just going to attempt to slow the progression of the disease. And usually, if it's not Alzheimer's dementia, which that's what these medications are kind of intended for, I really tell them that, hey, they haven't really been studied in your type of patient population. Behavioral mood medications can be very helpful because they can get very agitated. Medication reconciliation, just kind of weaning down things that they don't need. Are they truly needing these pain medications? Are they truly anxious? Where they need to be on like Ativan and things that can probably even paradoxically worsen their dementia? And here I just have a list right here. When you think about med reconciliation, anticholinergics are the most common things that you think that you want to worry about, especially in the elderly. I just have a list here that you can just kind of review if you need to. Like, hey, so there's lots of medications that actually have anticholinergic properties that we don't always think about. we use a lot of neuro medications, and we are familiar with those types that have anticholinergic properties. But I mean, look at this. I didn't actually know some of these. Like, I think there's like a cardiac medication somewhere here that that actually has an anticholinergic property. But always good to kind of just review mechanisms of medication, especially if you're unfamiliar with them. Address sleep disturbances is pretty important. And then safety precautions, making sure that wherever they are, that they are in a safe environment, not leaving stoves lit, doors unlocked, driving when they have poor spatial awareness or are prone to getting lost. So kind of the takeaway point from this first part of this lecture is, really perform that comprehensive history and physical exam. That the money is really in the exam and the history. Figure out what that baseline is, and whenever patients have specific symptoms that they're concerned about, really try to make them elaborate. Like, what is that memory loss? Like, what do you mean by that? The specific type of dementia is very difficult to diagnose on first encounter. As a neurohospitalist, people come in and want me to tell them what type of dementia they have. And I'm seeing them in a very vulnerable state, especially when they're elderly, they're in the hospital, they're not used to this environment, they're going to look worse than what they probably were at home. And that's going to obviously scare families. And I had to kind of, give my initial thoughts, but kind of defer them to the outpatient, because that's usually sometimes whenever we can kind of say what they truly have based on their trend of their examination. So cases. So I think I have 4 cases just to kind of review what RPD patients can look like in various forms. I think most of these are kind of based on some of my experiences. So we have a 61-year-old female with 8 months of cognitive decline. So what that means is the first month, confusion in the house, trouble using the computer, and then stopped driving. All these things were new for her. The second month, some echolalia, kind of repeating herself a lot. The speech became very non-fluent, basically just nonsensical. Trouble even using utensils, unable to do chores. Month 3, cannot be left alone, easily angered, frustrated. And then these symptoms kind of progressed from there until she eventually presented. Basic vascular risk factors in her history and her examination, pretty cognitively impaired. The MoCA, which is like a pretty quick bedside test, sometimes very hard to do in patients with very severe dementias, impaired dementias. She got a 16 out of 30, was the best that she got. A lot of increased tone in the examination, but otherwise non-focal. Basic workup, serum, nothing to write home about. The spinal fluid, the basic spinal fluid, nothing to write home about. So I don't really show anything that's abnormal, just for simplicity of these slides. The EEG, it was abnormal. Periodic spike in waves, but there actually wasn't any seizures. And then, like we all love to get, we got here's the EEG, showing the spike in wave pattern. It's abnormal. We got a brain MRI, and the MRI was abnormal. So it's always validating whenever you have a patient who has some sort of dementia, and then you get correlating data, especially imaging, because sometimes that really helps. In this case, it actually did help. So this MRI, basically, I think it shows cortical ribboning around the bihemisphere, and then it showed some thalamic changes on flare and diffusion restriction, and we'll talk about this in a moment. So with that in mind, we sent for more specific markers in spinal fluid, and specifically 1433 and RT-QuIC came back positive. which kind of led to a very confirmatory diagnosis of Creutzfeldt-Jakob disease, or CJD. So what's CJD, right? Essentially is misfolded proteins in the brain. And I kind of here showed you a picture of what a normal protein looks like, just kind of for conceptual purposes. And what happens is these proteins look in CJD abnormal. And just those small little changes in this PRP protein leads to an accumulation of these abnormal proteins, eventually into a very fatal dementia. The types of CJD, the most common sporadic, basically it just happens out of nowhere. And a very small portion have a genetic cause of CJD. And there's an even smaller cause, which is acquired. That acquired being what you sometimes hear once upon a time, or as like mad cow disease, eating like infected beef. And then there are like certain populations, very indigenous groups. I forgot where, who they actually eat brains of people. I don't remember. They're called kuru, and the disease is called kuru. But obviously, if you eat infected brain, you're going to get CJD. So the survival, unfortunately, is 7 months, and definitely 90% die within 1 year. So it's definitely it's absolutely a terminal disease, a terminal diagnosis. How do they look? So they present with symptoms over 3 to 6 months. The cognitive changes that we talked about, the behavioral changes, the sleep disturbances, but there's something more that they have, and it's usually abnormal movements, dyskinesias. So like myoclonius, like jerky movements, bradykinesias, they're super slow, dystonias, ataxias, seizures. They have a lot of these extra things going on. How do you kind of formally diagnose it? So they're pretty good, even though it's a very rare disease. We've come up with pretty good consensus criteria. You know, you have to have the dementia that we talked about. You have to have some of these extra symptoms that like the myoclonus, the extrapyramidal, the visual issues, the akinetic mutism. And then to kind of like make it more slam dunk, you want the EEG pattern, which we'll talk about, spinal fluid confirmatory, and even MRI findings. So you obviously, you don't want to give anybody a terminal diagnosis, especially if there's a treatable option. But with all these different, if somebody checks the box on all these different parameters, it's really hard for you to not give them this terminal diagnosis. So in the serum, usually it's normal, like the patient that we had. Spinal fluid, the basic spinal fluid test can be normal. But the MRI is actually very, very helpful. So fortunately, with CJD, you see classic MRI findings, and the sensitivity is as high as 96%, which is actually very, very good. And specificity is 93, basically meaning if you see this pattern on an MRI and the clinical context fits, it's 93% of the time, it's CJD. So let's talk about this MRI pattern. This is the same MRI that we had. I put onto the other side this table with UCSF's CJD criteria, because they're actually very big in rapidly progressive dementia research, actually. Basically, I'm only focusing on the definite CJD. To be definite CJD, you want cortical ribboning. And what that is basically you see on the edges of this circle box right here, you see basically what's lighting up is like this, like basically it looks like a ribbon all around the cortex right there, right? But that can't alone be the answer. but you want supportive evidence as well as for definite CJD. So you want subcortical involvement in specific areas. And what some subcortical areas is this MRI here in this box. So you want to see certain areas like the thalamus, bilateral thalamus to be hyper intense. You want to be the caudate. You want to be the striatum. So it's cortical and subcortical patterns that really kind of give you that diagnosis. But like we kind of talked about, it's only 93% specific. So there are mimics of some of these patterns that we have to always be aware about, but we kind of use the clinical context to see if they have these other things that are more treatable. So cortical ribbon, you can see in other diseases, the pattern is a little bit different, but in hyperammonemia, so elevated ammonia, you can see it. In post-ictal state, so patients who had seizures, especially long seizures, you can get this cortical ribboning. And then the subcortical changes, a lot of metabolic and diseases can have these subcortical changes, like in Wilson's disease, which is a copper deposition of copper, or extrapontine myelolysis, essentially like rapid correction of sodium can lead to a very similar presentation. And all of these diagnoses have a kind of like a dementia presentation. So it's not always the easiest to tease out just with the MRI, which is why you want to get the EEG to be helpful. And it's almost always abnormal. Periodic bilateral sharps is what you typically see. And then CJD biomarkers, that's kind of like where the gold standard is. Thank goodness we have something that's almost gold standard and very, very, very good. 1433 is the old test that we used to do. Look, and if you notice that the specificity is only 80%, but then we have RT Quick, which has 100% specificity. So with the 1433, once again, it's not specific. What that means is other diseases can have positive 1433. It's not anything to do with CJD. It has to 1433 is a marker of rapid like brain neuron breakdown. That's all that means. And so you can see in so many other diseases that can have brain injury, brain breakdown. A little bit about just this. So obviously, like when you worry about 1433 and CJD, like you want to send these labs, and so we should be sending it more often, right? So we can like, in the discussion about CJD and whatnot. But it's not the easiest test to get, especially because the spinal fluid is actually a transmittable. You can transmit the prions in the CSF. So you want to handle it very carefully. And when you hand it to all these other labs for testing, you want them to handle it carefully. So our protocol here is if we're sending for CJD, any test that we need to send out for any other reasons we can't do. And usually those things are treatable causes, like me sending out my autoimmune encephalitis panel, because that's treatable. And so it's very tricky when you're trying to figure out what's more important, because you don't want to send contaminated spinal fluid to Mayo if you haven't ruled out CJD, but you don't want to send the CJD, and that prevents you sending out a treatable test like the Mayo autoimmune encephalitis panel. So it's a little bit tricky here how we can do CJD testing, but it's technically it's very safe, so I understand. Treatments, there's none. Takeaway point, the brain MRI is very sensitive for CJD. And we've had I've been involved with a few cases of CJD just in this 1 year here. And I will say is, from my cases of CJD that I've had, most of them have had abnormal brain MRI, even my most recent patient. But the caveat is, since I've seen it quite a bit, there's been actually 2 patients where there have been a normal brain MRI, but my suspicion based on the clinical presentation was high enough that I ordered the CJD and they became positive. One patient with no cognitive symptoms early on, but we had other suspicions based on his based on kind of how his symptoms progress. And then a more recent patient a few months ago who had cognitive deterioration and an abnormal EEG was showing those periodic spikes and waves. That was like, hey, we should probably send for CGG now because this EEG is very abnormal. Okay, case 2, 70-year-old female with 2 weeks of cognitive decline. Symptoms, just one week of headaches, difficulty doing a crossword puzzle, nonsensical speech. Second week, lethargy. Then she progressed to be more obtunded, not very interactive. She had a history of Sjogren's, diagnosed by antibodies, but not really on any treatments because not really having that much symptoms. On exam, I mean, she had a rash on her extremities. And then whenever I saw her, she was very obtunded, not interactive, able to move the arms and legs spontaneously. And here's a picture of her rash right here. Just, looks like it's a rash, but like doesn't necessarily doesn't look diagnostic for anything at that moment. We got a pretty broad workup, serum, kind of bland, CSF, normal, not normal, and then EEG, diffuse slowing. I'll kind of jump to like the gist of it because for time. The brain MRI was normal. We were kind of very confused on her case. It was actually very confusing early on. After a lot of pushing, our team eventually decided, let's just get a skin biopsy because this rash, although it looks very non-specific and we had some alternative explanations for it, we were diagnostically not getting any answers, and she looked very, very bad. She was obtunded essentially. So we got a skin biopsy, and it showed essentially like high levels of IgGs and A's and complements. A lot of things. Essentially, kind of confirming a diagnosis of lupus. So with her picture, with the skin biopsy, what's going on, we decided that her diagnosis was neuropsychiatric lupus. You also may know it as like lupus cerebritis. So lupus is basically, I'll just call it lupus cerebritis for simplicity. About 56% of patients with lupus can actually have neuropsych symptoms. And about almost a third of patients who have neurologic complaints are usually at the time of diagnosis. So it's kind of pretty common that you see neuropsych symptoms with patients with lupus. They can be vague as headaches, mood disorders, cognitive disorders, strokes, seizures. It's just honestly very, very, very vague, and there's no use in trying to be more specific about it. It could be anything. And then the diagnosis of lupus cerebritis is really based on the diagnosis of lupus and no other causes for neurologic symptoms. So you want the diagnosis of lupus based on, it's really blood tests, really. The ANAs, the double-stranded, the anti-Smith, CCP, C3, C4, antiphospholipid, all these things that sometimes Room can help you with. I didn't actually put it on the initial slide, but she had a lot of these inflammatory markers are abnormal. So it did support the diagnosis of lupus already. Other things beyond just like the rheumatology markers is you can have hematologic issues like cytopenias, like a hemolytic anemia or thrombocytopenia. The brain MRI can be normal, like in our patient. EEG can show nonspecific slowing or seizures, and the CSF can be normal. And in our case, I think it showed a little bit of elevated proteins, but it didn't help me initially at all with her diagnosis. You treat with immune medications because this is an autoimmune encephalitis, although there's no antibody per se that we found specific. It was just more based on the skin biopsy, the IVIG, the Plex, cyclophosphamide, which we also gave in our patient, rituximab, and then for maintenance treatments, because usually they need maintenance medications to not go into one of these flares again. Prednisone, mycophenolate is always important. Takeaway point, when there's an opportunity for a biopsy, other than the brain and spinal cord, you should really try to pursue that for diagnosis of dementia or rapidly progressive dementia specifically, because sometimes non-neurologic tissue can be very helpful in supporting a diagnosis when you can't really touch the brain. And then also, not all autoimmune encephalitis are diagnosed via autoantibodies. So case 3, a 55-year-old man who presents with 6 months of episodic confusion. So 6 months ago, confused on how to pump his gas. But he was able to drive the car, just very confused on how to pull up to the gas station and which side his gas tank was. His wife told this story. 4 months ago, he got angry on a plane because he wanted to go to the basketball game instead of seeing his cousins. It was like a sporadic bout of anger, and it was hard to redirect him whenever he was angry, and it was very odd for him to be this way. And between these episodes, he was actually very normal. Not really any important medical history. His exam, he was alert, not oriented, but what I noticed on his examination was he had a high compensatory mechanism. So what I mean by that is when you talk to him, you ask him like a question like, oh, where are you from? And he would answer the question incorrectly because his wife confirmed that. I would correct him, and then what he would do was like, oh yeah. And to most people, when somebody acknowledges their mistake, you think that, oh, they know what they're talking about. But I had a hunch that he didn't really know. And so I would ask him like 5 minutes later, oh, hey, by the way, where are you from again? And I would ask him again, and he would get it wrong again. So I knew that he really wasn't grasping what I was saying, even though I told him the answer. So definitely something was wrong, but he's 55, and this is not a very common presentation. The serum, unrevealing. Spinal fluid, very unrevealing as well. And the EEG showed diffuse slowing. The brain MRI was really non-specific, but what I just wanted to highlight was that his MRI had some atrophy, and it was like parietal atrophy. So, which was read as like atrophy greater than expected for his age. So, there's something going on. There's some sort of dementia going on. He has some behavior issues. He had some cognitive issues, but it was episodic though. What the wife said, like he had periods where he was normal, but clearly something was going on. So, with all this in mind, we got a lot of Alzheimer's marker, and the Alzheimer's marker were actually abnormal. So in this 55-year-old man who was actually very, very high functioning up prior to 6 months ago, he had very classic Alzheimer's dementia level markers. Here is actually kind of his test results, roughly, and for simplicity's sake, where I highlighted, when you do this Alzheimer's synapse test, they give you this really pretty graph right here. And essentially, it kind of tell you how confident they are that this patient has Alzheimer's dementia. And you can see highlighted in this box right here, this little marking was where his kind of profile ended up being, and it was pretty consistent with Alzheimer's. So it was very, very, very easy to confidently say like, hey, you have Alzheimer's dementia. So Alzheimer's dementia, it's actually more female predominant, and the average age is between 70 or 80. But once you're at age 65, you start having a 10% risk. So he was very unusual. He was 55, way younger than the average. So that's why he presented with only 6 months of symptoms. So it seemed like a rapidly progressive picture, but teasing things out, it actually ended up being bread and butter Alzheimer's dementia. You have the cognitive and behavior issues, as noted, are really early on. And then when we do the imaging workup, the brain MRI is very, very helpful, but in the sense that you can see atrophy. So for him, MRI was helpful because I really shouldn't see that much atrophy because he was otherwise healthy. And a 55-year-old shouldn't have atrophy yet, but he had pretty extensive atrophy. So it kind of clued me in that, hey, he probably does have an Alzheimer, like one of these more classic dementia types. You can get PET scans and they can show parietal temporal hypometabolism. So areas where there's just less kind of blood flow or um, neurons firing, essentially. Imaging, other imaging includes like amyloid PETs and tau PET, which I kind of alluded to as as um, as basically tests that you can only do on a research basis. But with the amyloid PET, the really big one right here, I kind of showed a normal brain, a patient with Alzheimer's, and then a patient who was normal at the time of the amyloid, but then 3 years later developing Alzheimer's. So you can see that amyloid PET is coming quite into use as a marker for as a pre-dementia screen, not being able to use yet commercially, but it's definitely being used on a research basis for clinical trials at least. And then for the tau PET, another marker that you use for dementia, here's a picture of a patient with Alzheimer's, and you see temporal and parietal hypermetabolism, lots of tau buildup, which is a pathologic thing you see in dementia. The CSF, the basic profile is pretty normal, but then you can see decreased and increased markers like the tau that we talked about. And for him, this gentleman actually got genetic screening because of his age, because it was concerning for an onset or a familial variant of Alzheimer's. And so he actually had, I don't remember actually if he actually had positive testing, but I know that it was tested. I just haven't followed up with him because he's not my patient, outpatient. The prevention, the bread and butter things that we talked about, the cholinesterase inhibitors, or like an NMDA antagonist. And then, as you guys probably heard in the news in the last year, this aducanumab, which reduces amyloid plaques, which is thought to be very important in Alzheimer's pathology, is very controversial in the treatment for Alzheimer's, but it's kind of there, but it's not necessarily commercially available at this time. Takeaway points: patients with dementias can have many compensatory mechanisms, making symptoms seem less noticeable. So my last case, 61-year-old female with 8 months of cognitive decline. Symptoms: there's some cognitive issues, some personality changes, hypersomnolence, fluctuation, basically like awake and sleep cycle issues, basic vascular risk factors, and a pretty poor mental status exam with a poor MoCA on presentation. Unrevealing serum labs, unrevealing CSF labs, moderate generalized slowing, which I would expect given kind of her presentation and that MoCA. MRI, very, very abnormal, kind of actually very helpful. What you can see highlighted or with the red arrows is you see areas of T2 flare changes with some vasogenic edema. It's a kind of bilateral. It is very abnormal, like you would not expect this in this type of patient. And then when you look at an SWI, which is a sequence to look for blood, areas of microhemorrhages scattered throughout her brain. So this kind of helped us give her the diagnosis of CAA related RI, CAA-ri, or cerebral amyloid angiopathy related inflammation. So what that is it's basically a disease where you have these amyloids, which you see in Alzheimer's, and they're kind of deposited in the blood vessels. And when you do that, these blood vessels are very friable. They can rupture, they can bleed, hence why you see bleeding on MRIs. You see it mostly with patients above age 60, and they present with, the basic cognitive behavioral changes, and also sometimes with the additional seizures, dyskinesias, sleep disturbances. And there are diagnostic criteria for CAA-ri. that are out there. It really just involves the story, the age, and MRIs with the classic findings, such as this patient that we talked about. Here, just, is basically a similar MRI. I won't necessarily go through it per se, because it's actually very similar to the other patient. Really what helps you is the flare changes plus lots of microhemorrhages everywhere, which I kind of highlighted in this box right here. Mimics, lots of mimics to CAA-ri because it has flare changes, it has some vascular issues. So strokes and lymphomas and cancers all can look like CAA-ri. And so usually these patients have a pretty extensive workup for all of these things to kind of rule in, rule out these things. The workup is pretty normal most of the time. So that kind of like sometimes, but some of these other mimics have normal workup, like strokes can have usually have normal workup. And so it's a little bit tricky, but usually the flare changes and the microhemorrhages in somebody who's of that age, like above like 60, 70, it's kind of classic for CAA-ri. You treat it with steroids. It's an inflammatory disorder. So you give steroids, like high doses, and then you taper it. And if they're very, very severe, you can do things like methotrexate, IVIG, or like rituximab, cyclophosphamide, mycophenolate. And if they're really critically, so actually the takeaway point is, if somebody's super critically ill and you will an infectious cause, then you can treat them with IV steroids or IVIG, and it's kind of like a Hail Mary thing, which in this patient, we actually knew what the diagnosis was, but like we could technically have done it if you didn't know what it was at all. Say like if this wasn't a diagnosis like 20, 30 years ago. So in this talk with all the kind of pearls that I kind of did throughout the talk, so perform a comprehensive physical history and physical exam, always the most important thing. So the specific type of dementia is very difficult to diagnose on first encounter. It's really helpful to do serial examinations. And for CJD, the brain MRI is very sensitive. So I know everybody freaks out by CJD because everybody wants to, for some reason, diagnose CJD. It's very odd. But if you have a normal brain MRI, many people, you should really like take a deep breath and just exhale, because you likely don't have CJD. Patient-wise. When there's an opportunity for a biopsy other than the brain or spinal cord, I think that you should always pursue those biopsies. Although they're still an invasive test, they're way less invasive than a brain or spinal cord biopsy. Not all autoimmune encephalitis are diagnosed via autoantibodies. Patients with dementias can have many compensatory mechanisms, making their symptoms less noticeable or seem like not a classic picture, like more episodic. And if the patient is critically ill and an infectious cause is ruled out, you can try a trial of IV steroids or IVIG to see if it helps the patient. And I put this here because I know that I remember as a trainee, there were a lot of things that I used as resources. Like I used like very, very, very like big books, and there are neurology journals. But I know as a nurse, as a PA or NP, there aren't that many things catered towards you guys. But I used to use this it was a podcast, but it's not a podcast anymore, and they only kept it as a YouTube video. But basically, it's called Brainwaves, and they have really good, also like intern resident level level of stories about these different types of workups that maybe I think that you guys would probably benefit from, like first seizure of life, and it's 15 minutes long, or like what's an agnosia, what is aspirin versus Plavix, like why we think about these things differently. So I leave it here as like, if you just want like something really easy to do when you're like on a subway or have some like 15 minutes of downtime, these are really easy YouTube videos to like stream. With that being said, do you guys have any questions? Okay, one question. Is there